there can be the rib which is wrongly placed, which can compress the nerves. So this is one of the most commonly affected area. This is the interscalene triangle. The contents are brachial plexus and subclavian artery. The second one is the costoclavicular space, which is confined anteriorly by the subclavius and infero-posteriorly by the first rib and the anterior scalene, and superiorly by the clavicle. So you can see this costoclavicular area. The third space is the subcoracoid space. This is the subcoracoid space. You can see mostly the brachial plexus being involved here. You can also have involvement of the axillary artery and vein. This is the borders are actually anteriorly. It is the pectoralis minor muscle which is coming from the coracoid process. Then you have posterior ribs 2 to 4 and superiorly by the coracoid process. So what happens is, if you have a brachial plexus injury, you will have a neurogenic toss. If you have a subclavian vein injury, vein involvement, you can have venous toss, and subclavian artery, you have arterial toss. So the causes can be either congenital, traumatic, or functional. Congenital, most commonly what we see is cervical rib and anomalous first rib. These are the two most common conditions. There are other conditions also. Traumatic, you have whiplash injuries and falls. And most importantly, when there is an injury, not only the injury but also the healing process can also cause troubles, which can also cause thoracic outlet syndrome. Functionally acquired, this is more common in young patients who are doing vigorous repetitive activity. So there can be a muscle inflammation which can lead to healing, and then the same kind of symptoms can appear. First, I'll talk about neurogenic toss, which is the most common one. About 90% of all the cases are of neurogenic toss. The brachial plexus is generally involved from CA to T1, but most commonly it is the lower plexus which is involved. Cervical rib, which is one of the most common reasons for it, it's present in 1 to 2% of general population, but most of them remain asymptomatic. Only 20% of the patients of toss have a cervical rib which is present. So one has to be very careful when reviewing the scans. And cervical rib can also be a predisposing factor for development of arterial toss, where there can be compression and development of aneurysm and aneurysm or stenosis. So the most common symptoms of neurogenic toss, as the word itself says, it will be paresthesias in the upper extremity, neck pain, and trapezius pain. There is a large study which was done where they tried to analyze all the symptoms. The most important symptom being upper extremity paresthesia. You can also have chest pain and occipital headache. Paresthesia in all 5 fingers are also noted in some cases. So, as I said earlier, the lower plexus of toss is more involved than the upper plexus. Compression of the nerve roots, which can happen, as we saw the anatomy, it can happen in the scalene triangle as well as in the subcoracoid triangle, but more commonly in the scalene triangle. There can be an abnormal aberrant muscle in the scalene itself which can cause this. There can be connective tissue thickening which can cause it, or the cervical ribs which can cause the entrapment of nerves. Scarring of the ribs, scarring from injury can also lead to this side effects. The second most common type is a venous toss, where the subclavian vein is compressed, which is mostly within the costoclavicular space. There is a mechanical compression and repetitive injury of the subclavian vein. And once there is repetitive injury, what happens is there is development of a thrombus. So it's also called as Paget-von Schlotterer syndrome. This is more frequently in young patients who are physically active. They are more common in males, and patients who are actually doing weightlifting and they come with repetitive upper extremity overhead motion. It's more common in those patients. The last and least common type is the arterial toss, which is present in about 2 to 5% of cases. In this, the subclavian artery is compressed mostly within the scalene triangle, and this is also caused mostly by the anomalous first rib, which ultimately leads to aneurysm or stenosis of the subclavian artery. Acquired types may be mostly seen in, as I said, it's mostly common in active males and athletes, in which the arterial entrapment can occur, especially between the pectoralis minor head and the tendon and the humeral head. So whenever a patient of toss comes, a multidisciplinary team should be activated. A vascular surgeon should be involved. A thoracic surgeon generally involved first. And nowadays we involve a hand specialist who have experience with all these brachial plexus injury management. So I generally involve a hand specialist for these cases. Radiology and physiotherapy are ancillary departments which are also involved in this case. And coming to the modalities, we have various clinical tests. I'm not going into the clinical tests. One of the important tests nowadays which is being recommended is the magnetic resonance neurography. This basically tells us whether there is any edema around the nerves, there is any surrounding signal variation in the nerves, and whether there is any pulsation artifacts, which gives us a fair idea of what level the nerve is involved and what exactly the extent of the nerve involvement is. For arterial and venous TOS, there are now mostly we are following non-invasive methods like arterial CT or MRI, and very rarely we use arteriography, especially if there is a suspicion of a thrombus or an aneurysm. Only then invasive arteriography is performed. These are some of the tests which have been mentioned in many of the textbooks, but the clinical significance of it will never clinch us the diagnosis. Maybe it will guide us in some way, but it will never clinch the diagnosis for us. Coming to the treatment, the first part of the treatment is rehab. We have to explain about weight reduction, postural mechanics, and relaxation techniques. And most importantly, activity modification is the priority in these cases, because what happens is there is repetitive activity of the same kind, then there is hypertrophy or fibrosis of the same muscle leading to entrapment of the nerves. So I think that's the first important thing. Focused physiotherapy is important, active stretching, targeted muscle strengthening, all these things are the first line of treatment. Then comes to symptomatic relief. You give NSAIDs, you give, some patients are also put on muscle relaxants, some anticonvulsants and antidepressants. Additionally, a lot of people have tried local injection of steroids, Botox, like anywhere, it's also used here, especially in the anterior scalene muscle. It's been not been very conclusive. The most important thing is physiotherapy and conservative management. At least we should give at least 4 to 6 months of treatment before considering any patient for surgery, because it's not a very rewarding surgery. At least you should tell that patient, okay, we have done everything before we give them an option of surgery. And one of the important indications for surgery is unremitting pain and worsening upper extremity weakness. And in neurogenic TOS, I think the first rib should also be removed along with the scalenectomy or scalenectomy. Few important facts are complete complete rib should be resected. Otherwise, what happens is there is a secondary fibrosis there, and then again there is irritation on the neurovascular bundle. A small amount of muscle should be left behind on the rib so that you don't avoid, and to avoid a subperiosteal resection. These are two important technical aspects of when you're doing a cervical rib excision. The approaches can be transaxillary or supraclavicular. The supraclavicular is supposed to be much easier because you have better control over the nerves. In the transaxillary approach, you might not deal with much of the nerves, but then the chances of brachial plexus injury are seen to be more with transaxillary approach in some studies. And especially when you're doing the transaxillary approach, you go between the pectoralis major and LD. So the dissection is actually more when we compare to the supraclavicular approach. And in this approach, what we have found, what many studies have found is there is a potential brachial plexus injury, which is mainly due to over manipulation and retraction. Infraclavicular approach is another modification which is used. This is mostly used for arterial and venous TOS, and generally it is used when you want the control of the main vessels of the from the aorta or from the central venous system. And one of the important thing is all three techniques have been studied extensively, but none of them has found to be superior to the other. And when you compare to neurogenic TOS, arterial and venous TOS, the role of surgeon and surgical approach is much earlier. There are some studies where they have used anticoagulation via direct catheterization and localized anticoagulation and with systemic heparin, but they have been found to be unsuccessful. So most of the patients will need some kind of surgery. So coming to the newer approaches, there are basically there is VATS excision of the first rib. That's one of the things, and robotic excision. So this is just a small video of how a rib excision is done. So this is, I have to thank Dr. Mohit and Dr. Hemang for this video. This is courtesy from AIIMS. This is how the muscle, the rib looks like through the VATS. The intercostal muscle is divided proximally and distally, taking care of the intercostal vessels. Once the rib is delineated properly, you can see that the intercostal muscles are very clearly seen, so it's not a very difficult approach. Then once that is there, you use the elevator to elevate the periosteum, and then you divide the bone in the middle so that you can get both the fragments easily and not cut at one end, because then the remnant part will be very difficult to remove. So Robotic also they have done transaxillary approaches to prevent pneumothorax, but I think it's just an overkill of doing something very simple rather than going through transaxillary robotic and doing a rib resection. So just to summarize, thoracic outlet syndrome is recognized in approximately 8% of the population. Treatment is initially conservative. 5% of the patients are diagnosed with are treated with first rib resection. Primary resection is performed preferably through a transaxillary approach. However, VAD, supraclavicular and posterior approaches are also reasonable. Overall, there is no significant difference in outcomes and complications, but between the widely used approaches, and that neither one is clearly superior to the other. Thank you.
With due respect to chairperson, sir, we'll have to break the session here. Unfortunately, because we have to do the inauguration, the Secretary Health is already here at the institute. So we would request you to kindly break the session. We'll continue after the inauguration ceremony, sir.
Thank you so much. So with this, we come to conclusion of this session. So do we take the questions at the end, means after the inauguration?
This question, we can do the questions, but we'll have to stop the next talk, sir.
Okay. So the session is open for questions. So do you have any, Dr. Pooja was having a question for Dr. Anula, I think.
I was asking, she did answer the question, but I think it's good for the trainees to know. I was just asking, do you normally do fluoroscopy and or ultrasound, sniff test or ultrasound before putting a patient through diaphragm plication? Because in the US that's routine, and that often will waste a patient's time because they're usually backed up and can't get to those patients. And sometimes the results are so subjective and you can't interpret them.
So for the interest of the audience, so can you answer this question again?
So usually we only do X-ray, CT scan and ultrasonography. Sniff test, fluoroscopy we are not doing it.
Yeah, same here, I think we also follow the
We
same.
are
So not
doing
mandatorily we are not doing fluoroscopy.
And because fluoroscopy sniff test is basically to diagnose whether it is paralysis or eventration, that is congenital or this thing. That for that reason we don't do that thing.
So, see, the thoracic outlet syndrome,
Yes.
during the early days, I have been used to doing thoracoplasties. So the posterior approach I have been doing for a long time. And none of the cases with the posterior approach developed any neurological complications, because the technique is you expose the cervical rib, keep as close to the first rib with the first rib elevator, which you use in thoracoplasty, so that you don't go near the nerve. But in the anterior approach, which is usually done with the plastic surgeon, I have seen quite a few of them, even though you retract the brachial plexus, develop neuropraxia and pain post-operative. This was not present in the posterior, but the axillary approach is quite cumbersome. So I have done, but this is my observation in the outlet syndrome.
Sir, I've done a few. I've done with the hand surgeon.
Yeah.
So
Yeah.
it is perfect.
So my question is to Dr. Yadav, sir, and to all the seniors present here. We had 3 cases of traumatic diaphragmatic hernia with ruptured stomach, and the patient was delayed for around week to 10 days with empyema on the left side. Everything was swollen up. It was very difficult to reduce it, but the main problem was to close the defect. It was badly infected, so putting in any mash kind of a thing, which is a foreign thing, was also difficult. We put a vicryl mash. Touchwood, we came out okay. But what should be the strategy in these cases where an infected patient, traumatic diaphragmatic hernia with empyema, ruptured stomach, what should be the strategy and it is a difficult closure, what should we do?
Definitely foreign metal cannot be used. And some of the tissue from the body wall itself, like pleura, or it has been described, I have not gone through, but it describes that anterabdominal muscles, they can be taken and they can be used to.
Gluten we have researched pericardial techniques. I've had a similar situation. in an empyema which was infected, with the diaphragm was attached, and he underwent repair with the glutaraldehyde preserved thick pericardial patch. Unfortunately, 20 years later, in the same area, he developed squamous cell carcinoma, and came back, and the biopsy proved. This was an anecdotal case, but he had bad fecal fistula after the first surgery. Bad fecal fistula. So we had to repair the colon, do a decortication, and he had a good, useful life. But 20 years later, came with pain, with ulcerative sort of mesh. Before we dealt with surgery, we took a little piece of it, sent it for frozen, and it came as squamous cell carcinoma.
Thank you so much for sharing this experience. I think, sir, we can continue the discussion because we have...
Pericardium can also be used, You remove the pedicle of the pericardium.
Excuse me, I think we can continue the discussion later on tea, maybe.
So we can all continue discussion over tea. It's just on the left, and we'll just set up for the inauguration. So we'll request everyone to join back in 10 minutes. Thank you so much.
So on behalf of all chairpersons, I thank the speakers for this session. Thank you so much.